Καλησπέρα. Είμαστε στην τελευταία συνεδρία της ημέρας και έχω τη μεγάλη χαρά μαζί με τον Κώστα τον Τούτουζα να συμπροεδρεύσουμε τον πρόεδρο του Council of Cardiology Practice, δηλαδή του τμήματος της Ευρωπαϊκής Καρδιολογικής Εταιρείας, το οποίο αγγίζει τους καρδιολόγους οι οποίοι είναι στο ιατρείο του. Καρδιολόγοι οι οποίοι δεν έχουν πάντα την πολυτέλεια του νοσοκομείου και οι οποίοι είναι πιο απομονωμένοι, όπως το ίδιο το Council λέει στο mission statement του, γιατροί οι οποίοι είναι πιο πολύ μόνοι τους και πρέπει να ξέρουν λίγο απ' όλα. Θα έχουμε τη χαρά να ακούσουμε τον Chair, τον Ferrini, να μας μιλάει για το διαβήτη σαν καρδιακό κίνδυνο, και πριν δώσουμε το λόγο στον κύριο Ferrini, να αφήσω τον συμπρόεδρό μου, τον κύριο Τούτουζα, να κάνει δύο σχόλια.
Hello, I would like to, Dimitris, I would like to introduce also in English now, Dr. Ferrini, who is the chair of the Council of Cardiology Practice. It's really an honor to have him back in Greece. Hopefully next time, although we always wish it, but next time he will be present and not only virtually. So he will tell us about, he will give a lecture about diabetes as a cardiovascular risk. And it's very interesting because even in 2021, we have new data regarding the impact of diabetes as a cardiovascular risk factor and also regarding the treatment of diabetes. So we are looking forward to hearing from you. Dr. Ferrini, your lecture, please. Thank you.
Yes, good evening, and thank you for your inviting me to your meeting. As you know, diabetes is a growing burden for all the world problem of illness, and this burden is going to increase dramatically in the future years. So the cardiologist must be aware of it, because indeed, diabetes is a cardiovascular risk. Why is it a risk? Well, lot of mechanisms are implicated in this risk, and very often they are intricated, but they all explain the dilatory effects of diabetes: hyperglycemia, hyperinsulinemia, insulin resistance, dyslipidemia. All these factors leads to cardiac and vascular injury, and that is by this way that diabetes is going to lead to complication. And as you know, classically we speak about macrovascular disease and microvascular disease, even if this distinction is quite artificial. But anyway, today I will focus on the macrovascular disease. What is the diabetes cardiovascular risk? Here on the left of the figure, you have all the macrovascular complications. First of all, coronary heart disease that implicates 15 to 20% of the diabetics, and that is the most reported and the most lethal complication. Heart failure, of course, is a very, very important risk, and we know it for some 5-6 years, because before people didn't focus on heart failures. It's the second initial manifestation of diabetes as complication, and its risk is particularly important in females. Peripheral artery disease, of course, is an important risk, and it is the first initial manifestation of diabetes, with here again a higher risk in females. And last of all, stroke, about 10% of diabetics. That is the more frequent in death of the diabetics patient. Microvascular complications, I just talk very quickly. Retinopathy, of course, neuropathy, because neuropathy is consequence is the cardiac autonomic neuropathy, and nephropathy, because this nephropathy of the diabetics is the leading cause of end-stage kidney disease. So cardiovascular disease is the main cause of morbidity and mortality in subjects with diabetes. And we can say that this complication occurred approximately 15 years earlier than in people that has not diabetes. And when the diabetes is present, female sex is not anymore protective against premature cardiovascular disease, as we can see in the general population. So what is in fact, practically, what is the way of death of the causes of mortality in diabetes? In the recent paper about that it's studying the study with the sitagliptin, that is Tacos, on 14,000 people, there was about 1,000 deaths, and half of these deaths were due to cardiovascular diseases. And in this cardiovascular disease, you can see that sudden death is very often, it's about 30%, acute myocardial infarction or stroke, and heart failure death. And these three items are, of course, something we must have in mind when we talk about prevention. So how can we assess the risk, the cardiovascular risk in diabetes patients? The last guidelines of ESC are clear about it. In routine assessment for all diabetics, there are only two examinations to do, is to search for microalbuminuria and to do an electrocardiogram. That's a class 1 recommendation. The second point, and it is a crucial point and this very discussion point, is how to screen coronary artery disease. The two tools are CTC or functional imaging, like echography, stress, or stress scintigraphy. But as you see, this screening of, as you see, the screening of coronary artery disease is only of 2B recommendation. That means that you might do it, but it's not a routine data. We'll come back again on this point. The third point, what's important is to look at the risk modifiers. What is a risk modifier? It's an item that, when it does exist, allows you to change the risk of the patient from one class to one more important class. What are these risk modifiers? First of all, the discovering of a plaque, femoral or carotid, by ultrasound, arterial ultrasound, and this is a 2A recommendation. And then came the calcium score in asymptomatic patients, the ABI, that means the index, the brachial index, the ankle brachial index, or the detection by CT or MRI of a plaque in carotid or femoral. This recommendation, the last recommendation, are the 2B recommendation. That means that you might do it, and you might do it above all in patients with moderate risk, because if you find these items in this patient, the patient will pass from moderate to high risk, and it will change your way of managing it. Note that EMT, circulating biomarkers, and risk score used for the general population are not to be used in diabetic patients. Let's come back now to the problem of the screening of the coronary artery disease by CTCA or functional imaging. What's its new that is that the coronary calcium score is a prognostic score, is of prognostic value, and that for instance, if you have a coronary or a calcium score of 0, this is a favorable prognostic in asymptomatic subjects. And each increment of coronary calcium score is associated with a higher relative risk of mortality. So yes, calcium score has prognostic value, even if it is not always associated with ischemia. Stress testing is aimed to look for myocardial ischemia, and indeed echocardiography, stress, or scintigraphy are able to detect silent myocardial ischemia that is quite frequent, occurs in this diabetic patient. About 20% of diabetic patients have silent ischemia. So these are some favorable points, but the problem is that all the trials evaluated the impact of routine screening for coronary artery disease in asymptomatic diabetics show no difference in cardiac death and in unstable gene occurrence in those who underwent stress testing or CTCA compared with current recommendation. And that's why the indication of this test are limited by recommendation. Here you have the 5 studies that study the interest in using this test in the strategy in diabetic patients, using echo stress, MRI stress, or CTCA. And as you see, this was strategic studies. That means that depending on the result of the test, the cardiologists decide to do or not to do coronary angiography and to treat the patient. And as you see in the results, except this little study, all the other studies didn't prove that this kind of strategy generally introduced in the diabetic patients had a significant effects on reducing the occurrence of unstable angina or cardiac death. All the results were non-significant, and that's why routine screening of coronary artery disease in asymptomatic diabetics is not recommended by the last recommendation. But however, it is said that stress testing or CTCI may be indicated in very high risk asymptomatic individuals. So let me see what the stratification of risk means in diabetics. As you know, the risk of diabetics is maybe moderate, high, or very high. Very high risk is defined by patients that have established cardiovascular disease or that have other target organ damage. That means proteinuria, renal impairment, left ventricular hypertrophy, or retinopathy. Or 3 or more major risk factors. That means age, hypertension, dyslipidemia, smoking, or obesity, or diabetic, but type 1 diabetes. That is not what we are talking about. These patients are at very high risk. The high risk patients are patients that have diabetic duration for more of 10 years without target organ damage, but who have any other additional risk factor, one of these risk factors. And the moderate risk are young patients, that means for T2DM, age of less than 50 years, with diabetes durations of less than 10 years and have no other risk factors. What does it mean in our daily practice? Well, there is a recent paper of 300,000 diabetics that are followed by the primary health care in Catalonia, Spain. That it is not a study; it's just a catalog of patients. And as you see, most of the diabetics of this population, about 53%, are classified in very high risk. Half of them have an ASV, a cardiovascular disease, and half of them are very high risk because they have a lot of associated risk without any cardiovascular disease. And about 40% are at high risk, and only 7% are at moderate risk. That means that when you see a diabetics in your study, well, you can say that about 90% of probability this is a high or a very high risk patient. So we have spoken about risk, but which is the responsible of this risk, and particularly is hyperglycemia the principal factor of the risk in diabetes. It could seem clear and logical because on the 20 last years, diabetics were treated with hypoglycemic treatment, and the target of the treatment was to decrease the glycemic. Well, in 2011, a cohort showed that a cohort of about 20,000 patients compared normoglycemic, impaired patient, and patient with newly diagnosed diabetes. And in this cohort, was seen that people that had any glucose intolerance had more incidence of cardiovascular events or death than the diabetics. And by analyzing the data, the authors said that 1 micromole increase in fasting glucose was associated with a 17% increase in the risk of future cardiovascular events or death, as you see in this figure. Unfortunately, these data were not really confirmed by large trials, and I don't show you all the trials, but I just show you a meta-analysis of Palmer in 2016. In that studies all the trials concerning the 9 available classes of glucose lowering drugs alone or in combination. And as you see, this is quite heavy table, but as you see, all whatever the drug, the result on the serious adverse event or myocardial infarction or stroke were not significant, as you see in the odd risk that are very spread and that not allow any significant conclusion. And in the paper of Palmer concluded that there is no evidence that lowering the glycemia was useful for lowering the risk of cardiovascular events. And this is confirmed by the most of the great CRT. For instance, a meta-analysis of ACCORD, ADVANCE, and the veteran study showed, of course, that an hemoglobin C reduction of 1% is associated with a 15% relative risk reduction, but only non-fatal myocardial infarction, and there was no beneficial effects on stroke, cardiovascular, or all-cause mortality, nor for hospitalization or heart failure. So it's not lowering the hyperglycemia doesn't seem the main way to lower the risk in diabetics. And this data has been confirmed by recent trials that you all know, the recent trials that demonstrated the effect of two new family drugs, SGLT2 inhibitors and EGLP-1 RAS. And these drugs had a very interesting benefit on cardiovascular disease, and this benefit was independent of glycemic control and of baseline metformin use. You know these drug class drugs. As you see here, the SGLT2 lower very dramatically the heart failure or cardiovascular death in patients with arteriosclerotic cardiovascular disease or with multiple risk factors. And same thing for the GLP-1 RAS drugs, with one of the main studies that is a leader study on 10,000 diabetes, and that show a decrease of cardiovascular events and deaths for any cause, on comparing to the placebo group. So for the first time, we proved that we can lower the risk in diabetes patients independently of acting on the glycemic level. And that is very important because it will, this is a new paradigm that changes our way to treat and these patients. So some key points. That's first of all, you must remember that small shift in the risk achieved from a population-based primary care strategy may lead to significant reduction in disease burden, because if you treat a small risk in a very huge risk population, you will be efficient, globally efficient. And it's also important to set goals according to the risk level, that means to stratify the risk, and prioritize anti-diabetic medication that has been shown to reduce cardiovascular events and not only useful in reduce glycemia. And we can consider now that combined reduction in hemoglobin glycated, systolic blood pressure, lipid decreases, and lipids decreases cardiovascular events by 75%. And what is important, that multifactorial treatment in diabetics still is underused. Just for finish my presentation, I just remember what the last ESC guidelines define as on the management of patients with type 2 diabetes mellitus. As you see, these guidelines consider that you must have treat the patient in 2 steps. The first step is to recommend to stop smoking and lifestyle recommendation. And it is maybe the most important fact in the diabetes. That is the class 1 recommendation. About hemoglobin glycated, it is contrary to achieve less than 7%. This is the first important thing to do. And then if you are, the second point is to look if there is an ACE-CVD cardiovascular disease or severe TOD. In case of this, if these are present, well, we have some goals that are to consider to achieve a systolic blood pressure less than 140, or if tolerated 130, and to start antithrombotic therapy in case of presence of cardiovascular disease. If there is no cardiovascular disease, well, all depends on the risk of the patient. In case of moderate risk, you don't have to make additional prevention goals. But I just remember, these patients represent less than 10% of your patients. In case of high risk, you have, of course, to reach systolic blood pressure, if possible, of 13 millimeter or 1300 millimeter of mercury. And concerning the cholesterol, in high-risk patients, you have to achieve 100 milligram deciliter in LDL-C. And if you are in patient with known cardiovascular disease, the LDL-C reduction must achieve 70 milligram deciliters. And in case of cardiovascular disease, you have to discuss the introduction of the new classes of SGLT2 or GLP-1. Okay, this is a class 1 indication. If you have cardiovascular disease, that means that you must introduce this therapy class, and it is a class 2B if you have just TOD. That means that you might use this new therapeutic classes. This is the step 1 of in the management of this patient. And as you know, after having do your examination of the patient, have really strictly defined his risk, his level of risk, you are going to pass to the step 2 And in this step 2, you can intensify treatment based on the 10 years cardiovascular disease risk. I'm talking about people, the patients that are in high risk. So you have to establish the 10 years cardiovascular risk, the lifetime cardiovascular risk and treatment benefit, the presence of comorbidities and frailty, and of course, you must take account of the patient preferences. And based on this data, you have to more affine your targets concerning systolic blood pressure. You have to, if possible, go less than 130 millimeters, and if possible, go less than 70 milligrams of LDL. And if you haven't already done, propose the new classes of SGLT if you are in high risk of heart failure, or GLP-1R if you are in high risk of cardiovascular events, especially coronary artery disease or peripheral artery disease. If you are in a very high, if you are confronted to the very high risk patient, then again, you have to intensify treatment in this step 2. And according to this same data, you have to decrease systolic blood pressure, if possible, less than 130, decrease the LDC level, but here in the very high risk, you have to go less than 55 milligrams, and you have to introduce, if you have not already done it, the 2 new classes of gliptin or GLP-1R. And then, but it is a class 2B, you might discuss the introduction of very strong antithrombotic agents, for instance, the DAPT, or novel upcoming intervention, for instance, colchicine, but this is just a 2B class, and it is very to be done case by case. That's all the data I have to share with you concerning the diabetic risk. I think the most important things is the paradigm shift that we have now to consider the patient as a cardiovascular disease risk that is independent of the level of glycemia, and then to prevent macrovascular complications of not, I don't speak about microvascular that are related to the level of the glycemia, but for macrovascular, you have to use priorly drugs that now have proved their efficacy in lowering heart failure complication or cardiovascular complications. Thank you for your attention.
Dr. Ferrini, thank you very much. It was really a fantastic overview of the guidelines. It seems complicated, but we have to get used to that in everyday clinical practice. And we're really glad that you really focused on the recent details and the targets of our treatment. Another also very important thing that you mentioned, observation, was that the role of hyperglycemia, which is not relevant to our outcome. So we have to focus on treatment in diabetes mellitus, to avoid the microvascular and macrovascular complications. I would like to ask you, how difficult it is to apply all these guidelines in the office of the everyday clinical practice? I mean, to examine the 10-year cardiovascular risk factor, the lifetime cardiovascular risk factor, to categorize the patient to moderate or high risk patient. Do you think that this is the everyday clinical practice of a cardiologist?
I think it is. I think that it is because we are going to see more and more diabetics. As you know, the guidelines consider that you have to see the patient for one specialized consultation. That is only the goal of this consultation is to stratify the risk using all the tables of the cardiovascular risk or the lifetime, in order to have a very precise idea of the risk and to share with the risk and the benefit and the balance benefit risk of each class therapeutic with the patient. So I think this is very important. The other point is the relationship with the general practitioner and the diabetologist. I think this may be different from country to country, but in France, we just start now to make understand our colleagues, the diabetologists, the endocrinologists, the importance that not to focus only on hyperglycemia. But at the beginning, it has been difficult. And now I know that I think the problem is, should cardiologists start the new drugs, gliptins or the GLP IRA directly to the patient? I did start for the gliptins. Now I start to give it, but it might be difficult.
Okay.
I don't know what you think about it.
I think we use it in our clinical practice. We use it in established coronary artery disease, SGL2 inhibitors. And however, it's a point that you make. I mean, cardiologists should prescribe these drugs. And I think in Greece, it's more comfortable to do it. Of course, also the medical general practitioners and other doctors who treat diabetes, it's more easy for them to prescribe, but also cardiologists prescribe. One more comment, I would like your opinion. I mean, we should make it clear to our audience that in high-risk patients without established coronary disease, LDL should be less than 100 milligrams per DL. So I think that 95 or even 100% should take statins, should receive statins. Blood pressure should be less than 140 milligrams of mercury, millimeters of mercury, as you mentioned. And another crucial point, which is very controversial, do you prescribe aspirin in the primary prevention in these patients?
No.
No, definitely no.
That's my point. But yes, of course, there is a great discussion about it. But you just, in which patient, in high risk or very high risk, you told me?
I mentioned the moderate and high risk.
Yes, I think in moderate, no, because all the recent data show that there is no result, and that there is the hemorrhagic, the bleeding risk is almost probably higher than the benefit. Even above all in older patients, because in older patients, you know, recent paper consider that maybe there is a cancer risk and an increase of cancer risk in this older population with aspirin. So the problem may be, the discussion would be for the very high risk, of course, without cardiovascular disease. If you have a cardiovascular disease, of course, you give it. But if it's just very high cardiovascular risk, you should consider the risk benefit. And I think if the patient is really at very, very high risk and that he has no bleeding risk and is not too old, less than 75, yes, maybe you can discuss aspirin.
Okay.
But it's very reduced population, and we are not now giving aspirin to all diabetic patients as we used to do it in the past.
Yeah, that's.
I don't know if you agree with it.
I agree with you. I agree with you. And before 2019, 18, every diabetic patient received aspirin. Now we stopped that, and we'll see the results. Finally, one last question, which is very crucial to our to cardiologists. You mentioned the guidelines regarding the stress test for testing for evaluating coronary artery disease in asymptomatic patients with diabetes mellitus. It's categorized as class 2B. In your clinical practice, do you often use stress testing for these patients?
Yes, yes, of course. As everybody.
So
yes,
you upgraded.
Because yes, I know that maybe I shouldn't, but when you're face to face with a patient, you feel that, well, I'm sure there is something in this coronary, and you ask it. Even you ask it because the general practitioner is asking it, and he has told the patient, "Oh, you should look at it." And if he's diabetic, the endocrinologist, he is very aware of this. He asks this kind of. So I do it. The problem is how do you manage the patient after the examination when you discover an asymptomatic coronary disease? The risk is that then you precipitate the patient in vascular. Yes. So I shouldn't do it, but I do it probably more than the recommendation tells me.
This is also my impression that we do it also. We upgrade it in the clinical practice. And by chance today, the American guidelines for revascularization were published today in JACC. So it's interesting for us to read it.
Yes.
So I think we had a wonderful lecture, an overview for the treatment of patients with diabetes mellitus. We really thank you for your contribution to our Congress. We are looking forward to have you back here in Athens. Thank you.
Thank you. Thank you, Konstantinos. Bye-bye. Bye-bye.